Hello, everyone, and welcome to Heads Up, the weekly webcast and podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel, migraine strategist, founder of the Facebook group Migraine Nation, and chronic daily migraine survivor. I am super excited to be here this week with Dr. Tim Smith. Dr. Smith is the CEO of Study Metrics Research. He has also conducted numerous clinical trials in the area of migraine and migraine medications, and he is the vice president of the National Headache Foundation. Hi, Dr. Smith. How are you today?
Very well. Thanks for having me again.
Thanks for being here. I think many people have started to notice that often when Dr. Smith is here, we have some exciting new news on either an FDA approval for a new medication, or we have some just basically new medication news. And today that is the case. We are talking about a new medication that has been approved by the FDA, and today that is Trudhesa. It has been approved for the acute treatment of migraine. This is interesting because it uses a very new technology to deliver a medication called DHE, or dihydroergotamine. Now, this is not a new medicine or a new drug. It is a new delivery technique. So we are going to talk about this. We're going to talk about how effective it is, and stick around for the end because we will remind everyone how DHE itself works on migraine. So Dr. Smith, Trudhesa is not the first nose spray to deliver DHE in the setting of migraine, but what makes Trudhesa different from other medicines that we have available to us?
Most of your viewership is more than familiar with Migranol, the brand name product that was marketed, I think it was in like 1998 or 99 when it first came on the market as a nasal version of DHE. And DHE has been around for 70 some odd years. So you think about this is the newest technology to treat probably the oldest drug that, to deliver it. And basically that is what is different about this. It's the same medication, which there's no doubt that DHE works for migraine.
Right.
But what we have with this new product is something they call a Precision Olfactory Delivery, or POD, or POD, we say sometimes for short.
Right.
And basically what the company that produces this, it's a company called Impel Neuropharma, and they are out of Seattle, I believe. And they've developed this, it's a device. It's a aerosolizer. Basically, it takes the Migranol, or the equivalent of the Migranol brand of DHE. It's the same liquid in a small glass bottle, and you attach the sprayer device on top. And basically it aerosolizes it and sprays it out in a very fine plume of mist that is directed towards the upper nasal space. And that appears to be the key, is getting this fine mist in that upper airway space, upper nasal cavity, because that is where the medication has the best chance of being absorbed. So with a smaller amount of fluid, you can reach that area and get superior concentrations of drug into the bloodstream. And there's another aspect to that too, and I don't want to belabor the point, but there's at least a theory that perhaps by delivering the medication in that area, you can actually get some uptake of the drug molecules along the olfactory nerves and take it and deliver it back to the brainstem. So it's kind of like the superhighway to the brain. It gets the medication directly to the area where it's needed most. So there's a couple of those considerations, but it's that very fine mist plume of medications that are directed to the upper airway space and upper nasal cavity that seems to make this have a better chance of being effective. And the pharmacokinetic blood levels really reflect that. It's comparable to getting an IV.
Right. I think that that's what a lot of people are going to cue into, is that I think many people who have chronic migraine or have been in status migrainosus may have experienced DHE infusions. And so the goal here is to get the blood levels, am I correct, to be somewhat the same as an infusion. And that's what possibly they have managed to do here. Am I correct?
That's correct. And neurology clinics that have infusion centers or headache clinics that do infusions, the patients that come in and take those infusions are the ones that are refractory and struggle, and they're not getting relief. So they come in and get an IV infusion. And through this technology, you could potentially get comparable blood levels without having to go in for an IV.
Right. So how effective was Trudhesa in the clinical trials?
So in the clinical trials, they looked at the usual endpoints, and the main study was just published in the Journal of Headache. It was primarily a safety study to look at because you're taking DHE, which we understand this product. It's not like there was some mystery as to the safety of it, but what the pod device does is it admixes the DHE with the propellant, an HFA repellent. This is the same propellant that is used in pulmonary inhalers, and we know that it's safe. But to make sure that there's no incompatibility or deterioration of the DHE molecule, which can be unstable, they don't admix the HFA with the DHE, the propellant, until right at the moment of administration, and that's what's in that device that goes on top of the bottle. And so when they did this study, it was a safety study, but they captured a lot of primary outcome data, the type of parameters, the endpoints that we always look at. And the 2-hour pain-free rate was 38%, which is quite good. And 2-hour relief or freedom from most bothersome symptom, and that's the nausea, the vomiting, the light noise sensitivity, was at 52%. 2 hours complete freedom from the most bothersome symptom, and then the 2-hour pain-free rate, pain reduction rates, or pain relief rates was 66%, and that's where they go from a moderate or severe headache to mild or none. And so these numbers are quite good, and people who follow these numbers will recognize that across products, this is a favorable set of outcomes for us.
Right. So did Trudhesa work after one dose when they were looking to get this data, or were the subjects in these studies taking more than one dose?
They were allowed to, in this long-term study that I just described, the subjects were allowed to rescue in 2 hours, and they could do that by taking some other, analgesic or NSAID and the like, or they could opt to take a second dose after 2 hours, and that's the way the study was designed. The prescribing rules are the patient may take a single dose, and then they can repeat. They have to wait at least an hour. And so between that 1 hour to 24 hours, they can take one additional dose, but no more than 2 doses in a 24-hour period. And there's also a restriction of no more than 3 doses in a week. And that's just the general DHE administration rules. And that's what was studied in the clinical trial.
So this is to me, was possibly the most interesting thing that came out of this study, because we are almost always told as people with migraine, take your medication as early as possible. It's most likely to work then, which we all find to be very difficult instructions, because we're also told to be careful how much you take so you don't get medication overuse headache, et cetera. Those are 2 very difficult instructions to follow at the same time. So did patients in this trial have to take the medication right away for it to work?
They did not, and it's important to remember that this was a safety trial, and basically what the investigative sites were trying to do is find patients who would treat at least 2 migraine attacks per month with regularity. So they didn't want to put too many restrictions on, how and when they could take, as long as they could treat a qualifying migraine. They actually allowed them to treat early and when the headache was still mild, or they could even delay and treat as late as 4+ hours late. And I think most of us, advise against waiting, as you pointed out, but
Right.
it was allowed in the trial, and interestingly, their numbers still looked good. So delayed, treatment with this product was still showed some favorable outcomes on that.
Okay. I think what you're trying to say, Dr. Smith, just so that everyone knows, is that many of the trials that we talk about, efficacy or whether or not it worked is the main outcome that they're looking for. And so it's easy for us to report the data straight away and say, this is how well it worked, et cetera, et cetera. And that's not exactly the first thing they were looking for in this trial. They were just trying to make sure it was safe. Is that what, when you keep answering my questions that way, is that what you're trying to make clear to everyone?
And so they actually considered these effectiveness measures as kind of exploratory effectiveness measures. The primary outcome was the patients had to go in periodically and have a fiber optic rhinoscopy done by an ear, nose, and throat physician to inspect their nasal cavities and make sure there were no abnormal changes taking place. And they actually had to do smell tests too. It was kind of interesting. They would have these little scratch and sniff pages. They had to identify the scents, the smell that they were doing in a blinded fashion, and to make sure there was no changes happening to their olfactory sense or their sense of smell.
Okay. I do believe there was one important contraindication that came out of this study. Can we discuss any contraindications that they have published related to Trudhesa?
Well, the main thing is that DHE, we have to always remind ourselves that this is an ergot derivative, and the ergots are vasoconstrictors, and they have their issues that you have to be mindful of, and some warnings. For many of these are the same for the triptan class as well. But the one thing that's a contraindication for Trudhesa is concomitant use with medications that inhibit a liver enzyme called CYP3A4, and that cytochrome P450, some people call it the 3A4 isoenzyme. Not to get too technical, but this is the enzyme that principally metabolizes Trudhesa, and if you interfere with that, then you can build up some higher levels of the drug in the bloodstream, and that can lead you to some of those vasoconstriction type side effects and things that we worry about patients get with Raynaud's phenomenon, or who have heart attack and stroke issues, any circulatory compromise, then that can create some problems. As this is the case for any ergot compound, but that's particularly what we want patients to know about on this. The medicines that interfere with the cytochrome enzyme we're talking about are a couple of antibiotics, erythromycin and clarithromycin, or Biaxin and erythromycin, and then a couple of the antifungals, itraconazole and ketoconazole, and then some antiviral medications that are used for HIV, sort of retrovirus antiviral agents. So they're not huge and widely used on a regular basis, but they can be deployed occasionally if someone was treating a fungal infection or something like that. That could be an issue. There are a few other things that can interfere with this CYP3A4. One interesting thing is grapefruit juice. So patients are cautioned not to take a significant amount of grapefruit juice with medications that depend on the 3A4 enzyme.
Right. So what side effects or adverse reactions did people have when they took Trudhesa?
Yeah, the number one in this in the study, and is going to be in the product label, would be nasal congestion, and that's very common for nasal administered medications to cause congestion. It's just you put a chemical on your nasal membranes, and there's a chance you're going to get some congestion from that. Second was nausea, and it was a little less than 7% of patients had nausea. Nausea is a very common side effect of DHE. In fact, given intravenously, it's quite common. It's much more than the 7% or less that was seen in these clinical trials. And I think that what's going on there is when you get an IV, you get that initial peak that overshoots the, the concentration is a spike right on the front end. And that's not the spike that makes you better, but it's the spike that causes side effects. And so with Trudhesa, you can get the therapeutic levels you need for the desired clinical effect, but you avoid the spike and the overshoot, which accounts for the side effects. So the nausea was only 6.8%. Then there was nasal discomfort and abnormal taste. And you'll know that these 3 of the top 4 side effects are really part and parcel of using a nasal medication.
Right. So this is actually a question that was written into us by one of the people that watches Heads Up. Someone said, I've tried other nose sprays that were indicated for the treatment of migraine and they didn't work for me. Should I try Trudhesa still?
Well, I think that, if you think about the medications that are nasal treatments for migraine, and there's Zomig nasal spray, Imitrex nasal spray, and then the Migranol nasal spray, which has been marketed a long time as well. I think the thing I would say about the triptan nasal sprays, Zomig and Imitrex, is those are very, they're targeted to a single or 1 or 2 serotonin receptor subtypes.
Right.
And in fact, it's a very finely tuned, specific receptor effect, which fortunately works for most migraine patients. But Trudhesa has a broader effect across a range of different receptors. And so that might afford an opportunity for someone to get better with that broader spectrum. It's kind of more like it's more like a scattergun as opposed to a laser focus.
Right.
And for some people, that might be a big difference, a difference maker for responding. So if they've tried triptan nasal sprays and they didn't work, by all means, this would be a reasonable thing to try. And then as compared to Migranol, the blood levels with the Migranol version are not very good when compared to what we see with Trudhesa. So if they've tried Migranol and didn't like it, there's every chance that the Trudhesa version of Migranol nasal spray, number 1, would be better tolerated, and number 2, have a higher degree of effectiveness. So it's I don't think it's a wasted effort for them to try.
Okay. So do we know when Trudhesa will be available to us?
It's been announced that, the FDA approved it on the 4th, September 4th, just before the holiday weekend. And it looks like it's going to be on the pharmacy shelves by September 24th. So
okay.
Coming up soon.
Okay. And do we know if there'll be a coupon program, how the insurance companies are going to pay, et cetera?
I understand that they will, but I'm not familiar with the details on that, and I haven't seen a quoted price, target for that either. My guess is it's probably going to be comparable with other new abortive therapies when they come out.
And without getting too bogged down in the details, can you quickly remind us how DHE or dihydroergotamine works in the acute treatment of migraine?
Well, I guess the main thing is that it's a serotonin agonist. So, most of the medications we've been using for the last almost 3 decades have been the serotonin agonists. And whether it attaches to one of the, as I said, a laser focus on a 5-HT1B or 1D receptor, or then now we have the 5-HT1F receptor agonists on the market. So there's a number of these different serotonin, we call them 5-HT, that's just another name for serotonin, for those 5-HT or serotonin receptors. And the DHE, and the active ingredient in Trudhesa, is not quite as specific to a single serotonin sub receptor type, and so it has more of a broader range of effects. But it basically, it causes a little bit of blood vessel constriction. It decreases inflammation of the dura and the perivascular space of the blood vessels that course through the cranium. And then also it helps to inhibit pain transmission on the trigeminal nerve, which is the main pain transmission pathway that affects migraine patients. So
Okay.
it works in all those ways, and so we've used it. It's been a mainstay for decades. So there's
Okay.
hardly any scrutiny on whether this medicine works or not. It's just the new delivery system should help patients be able to get access to it, use it in the comfort of their own home in a way that is highly effective and doesn't cause as many side effects.
Right. And you always know that I like to ask for any parents that are watching that have kids with migraine, or if there's any younger people watching, if we know if there's any plans to test this in people under the age of 18.
I'm not aware. They've not started any of those trials at this moment, but as is required from all new products for migraine, the company will be expected to do, pediatric studies, 17 and under. Usually they'll go down to 12.
Okay.
On this one, I don't see any reason why they wouldn't. It certainly seems like a reasonable thing to do.
Okay. Is there anything you'd like to add to our discussion of this new medication that has been approved?
Yes, this new old medication.
New old.
New medication, whichever.
Exactly.
I just a couple of other fine points on this. Some of the rules around Migranol still apply, and that is once you open the bottle and attach the sprayer device on top, it needs to be used within 8 hours, or it's a wasted dose, because DHE tends to start to decompose when it's exposed to air. So you got a good 8-hour window to use it, but the advice is don't open it and put the device on until you are intending to use it right away.
So is it a single use?
It is
Okay.
single use, and the dose is 1 spray in each nostril, and then it can be repeated, but you would use this after an hour, but you would use a second dose.
Got it.
On that. The other point I was just going to make is that there is a little rubberized stopper on the top of the bottle when you open it and remove the stopper out of the bottle to put the sprayer device on top, the pod device, and that is not a latex rubber stopper. So our friends with latex sensitivities, this would be to their it should be acceptable.
Okay. All right. Well, thank you so much, Dr. Smith. And thank you everyone for joining us on this week's special episode of Heads Up. Please join us again next week.